Uh, the next topic will be the morphology of the left ventricle inflow tract and outflow tract lesions. It's my pleasure to invite Professor Yan Ho. She will starting with the morphology of this type of the population with the congenital heart disease. Professor Ho?
Hello. In this session, I'm going to talk about left ventricular inflow and outflows, describing primarily the morphology of obstructive lesions. So to start with, we go even further upstream. And in this situation, we're seeing a partitioning in the region of the left atrium, which reduces or restricts flow to the left ventricle. So we have this portion here, the pulmonary venous left atrium, and we have a membrane or shell in between this and the left atrial outlet that's feeding into the mitral valve. So diagrammatically, this is the situation we are looking at. There's lots and lots of variations. And indeed, in this diagram, I have shown you a variation whereby the shell is more tilted, it's right underneath the fossa ovale. So if there's a secondum atrial septal defect, for example, flow comes through here, through the and down there. Whereas in this particular arrangement, the defect, the atrial septal defect, would be beneath the membrane and feed directly into the left ventricle. This is an adult heart that had been transplanted. And this is an explant heart, rather. You're looking down the left atrium, you see this membrane, and the still image shows you a slightly less impressive membrane. And this is the configuration. This is a membrane to be distinguished from a core triatriatum kind of situation, because this membrane is just sitting right on top of the mitral valve leaflets. Now moving to the valves themselves, the mitral valve can have two orifices, as in this example, one here and the other one here, because I've cut through this orifice to open the ventricular wall. And we see here two orifices in the mitral valve. The mitral valve may have leaflet dysplasia, as we see here, causing stenosis. And in this example, there's loss of intercaudal spaces and even commissural fusion, restricting very much the inflow into the left ventricle. And the third panel here, we see an elongated leaflet, more or less like a kind of veil-like configuration with diminished intercaudal spaces plus commissural fusion. You may see cases with dysplasia, with no course at all. To get one step further, you get this sort of configuration where there are no course at all, and instead the leading edge of the mitral leaflet is muscular, sort of like joining together of the two pepper muscles, forming a mitral arcade lesion. Again, severely stenotic situation. Then this is the parachute form. Can take two variants, one where you have a single or fusion of the pepper muscles, the other where you have one dominant pepper muscle and the other pepper muscle is very, very small. In this specimen here, we have one in which the pepper muscles are fused together. So we have one, essentially one pepper muscle, a kind of parachute configuration. And take that obstruction for one stage further, you may have one of these situations where there's no mitral orifice at all. There's just a valvular membrane interposing between left atrium and left ventricle. This is the same heart. We see one solitary pepper muscle. Now, when you come to outflow tract obstruction, there are various levels to look out for. Where exactly is this obstruction? May have subvalvular situation or valvular, supravalvular, and coarctation even. So we start off with the subvalvular level. We have anomalous insertions, a septal hypertrophy, and so on. In this example, we see a ridge here on the septal side, and in this heart, we see the ridge extending like a diaphragm all round, so circumferential ridge or diaphragm. And this is excision, surgical excision, showing the composition of fibroelastic tissues making up this membrane. Further subvalvular obstructive lesions, such as this one, a septal bulge, or in this case, caudal insertions directly across to the ventricular septum. Whereas, you know, the mitral valve normally does not have caudal insertions to the septum. And this is an example associated with a ventricular septal defect with malalignment into the left ventricle. So you see, look up to the outflow tract, you see the outlet septum deviated into the left ventricle, very severely obstructing the outflow tract to the aortic valve. And the longitudinal cut shows you just how obstructed this outflow tract is. Moving on then to the valvular level, and just to deal with the aortic valve. Then you can have 3 leaflets, 2 leaflets, 1 leaflet, and so on. And these are examples of those with 3 leaflets, disproportionate in this case, are 2 small with 1 big. This one, the leaflets are proportional, but very, very mucoid in appearance and thickened. The lower panel is acquired age-related calcific aortic calcification. So we see lumps of calcium and very, very tightly stenotic. And in histology, you see the calcification. Coming to the bifoliate or bicuspid aortic valve, this diagram way back in 1961 by Edwards shows you quite nicely that you have unequal sizes of the leaflets tend to be stenotic, and usually equal sizes can also give you stenosis. The unequal and redundant were deemed to be non-stenotic. So some examples of bicuspid aortic valve. It's not that uncommon, occurring in 1 to 2% of the population. There are basically two arrangements of the valvular leaflets, one to the other. The anterior-posterior arrangement is much more common. So the 2 coronary arteries arise from a more anteriorly situated sinus. It's usually a kind of ridge or raphe between in the anterior leaflet. Becomes stenotic early on in people, then in those with tricuspid kind of aortic valve arrangement. And we see here some very severe examples of calcific stenosis of aortic valves. But the lower panel shows you heart specimen from a teenager who had a stenotic aortic valve, but that's due to dysplasia of the valvular leaflets rather than calcification. Moving on to the unicuspid and unicommissural arrangements, then we have some examples here, tend to be very young infants that we come across these, and much less frequently is this sort of dome-shaped arrangement. There's an attempt to form 3 separate valve leaflets, but not quite successfully, so we have this kind of configuration instead. Then moving further upstream, we have the supravalva and then followed by the coarctation lesions. So what do we mean by supravalva obstructionative lesions? There are 3 forms basically: the hourglass form, the diaphragm form, and the diffuse hyperplasia form. This is an example of an hourglass configuration where the stenosis at the sinutubular junction. See how there's a kind of waist arrangement, and deep sinuses and deep pocket-like arrangement of the valvular leaflets. And over here, we see isolation of the coronary artery in the sense that the leaflet has come up and fused across to the sinutubular junction, isolating this coronary orifice. And here's a still picture of it, showing you just this waist-like arrangement. Then we have the diaphragm type, which we hardly see at all in the postmortem series. And this is one of the rare examples here, because I think it can be resected quite readily and relieved, opening up the upflow to the aorta. And this is a case with diffuse hyperplasia. So we can see the leaflets are also kind of run deep pockets, but we see the aortic wall is very, very much thickened, almost like macaroni, kind of pasta. See here, very, very much thickened. So diffuse hyperplasia of the aortic wall. So moving to coarctation, it is a discrete narrowing versus tubular hyperplasia, which describes a length of narrowing, usually in the aortic arch. So we see here some examples. In the older individuals, I tend to see a kind of waist-like lesion, whereas in younger individuals, I tend to see a shelf-like configuration of that narrowing or substrate of that narrowing. The location of the coarctation lesion can be preductal, paraductal, or postductal. So this is an adult heart specimen. We see a bit of narrowing there, and we see a dip, a waist lesion. And looking up from the cut descending aorta, looking back up to the isthmus, we see indeed a very, very narrow orifice. In this situation, there's likely to be a well-developed collateral circulation. These are complications which we don't see at all these days, hardly any. These are examples from our museum. Some of them go back to nearly 100 years ago. And we see here some rupture and dissections of the aorta post-coarctation lesion. So then, to summarize, the inflow and outflow obstructive lesions, and outflow, we can talk about the levels of lesion, the substrates, and so on and so forth. Thank you very much. Hello, in this session.
Thank you, Professor Ho, for the very nice introduction on the morphology. And now I would like to continue with the echocardiography part of this session. And it's my pleasure to invite here Professor Miss Kathy West. She will speak about echo assessment of the left ventricle inflow and outflow tract lesions. I would like to introduce Miss Katie West. She is the principal echocardiographer and the leading specialist sonographer on the adult congenital heart disease echocardiography. Miss West, the time is yours.
Good morning, everyone. Welcome back to this session. In this session, we'll run through both LV inflow and outflow lesions. We'll cover this all in the one talk, a little bit different to what was advertised in the program, but we will cover the content all together in one presentation. So when we're talking about LV inflow lesions, we really need to start before the flow even gets to the ventricle. So we can know that there are anomalies of the pulmonary veins. So you might see an anomalous pulmonary vein which drains into the incorrect chamber, and that kind of ties over with some of the atrial septal talks, so I won't cover that in this session. We can have stenosis of the pulmonary veins, and that can either be congenital or it can be associated with multiple ablations, or even we see it sometimes following a lung transplant. Moving through the circulation, one of the common mitral obstructions or LV inflow obstructions is called Triatriatum. There's the supramitral ring, there's the double orifice mitral valve, and there's also anomalies of the parachute mitral valve. And you've heard about all of these in the previous session with Professor Yin Ho. So we'll run through a couple of these. Collectively, the supramitral ring, which is a supravalvular stenosis. Lesions of the valvular disease and also subvalvular are known as congenital mitral stenosis. So we'll start with Triatriatum. So Triatriatum is a fibromuscular septum that divides the left atrium into two, like you can see in the image here. So we get this superior-inferior split or division of the atrium. So why is it called Triatriatum? So tri means three, and that's because we essentially have three atrial chambers when that left atrium divides into two. This is how it appears on echo. So in a four-chamber view, we do see this membrane crossing the left atrium. And in the image on the right, we see the colour flow. This is a five-chamber view where we're really investigating the mitral regurgitation as we normally would when we pan through the images. And at this point, the triatriatum does not seem to be particularly stenotic. But the lesson here is it's really important to pan all the way through the chamber. So with a little inferior panning, see now we've lost the aortic valve, we can see actually that this is quite turbulent. And when we put a continuous wave Doppler through there, we see that there's a mean gradient of 5 millimeters of mercury. And so this is considerable stenosis, or not insignificant stenosis. Here's another lesion, and this one it's a little bit more severe. We see with the colour flow even that there is a continuous gradient. So this gradient, unlike in the last example, lasts throughout systole and diastole. And we see that represented on the Doppler trace. In this situation, we really need to measure the entire RR cycle. We can see here there's quite significant stenosis with a mean gradient of 9 millimeters of mercury. Now, using 2D images, it can be really difficult to underappreciate the severity. So this is a nice TOE imaging. You see the opening there and you can see the shelf in the left atrium. But these images, the 3D images, really tell the story, I think. You can see that the opening from the superior portion of the left atrium to the lower part of the left atrium is really very small. You could almost planimeter that and assimilate that to a valve area. So we see the shelf there very nicely using 3D imaging. The triatriatum, if it's on the left side, it's called triatriatum sinister. This is the most common type of lesion. The membrane is always superior to the left atrial appendage, and that's an important anatomical landmark. In situations where there is also an atrial septal defect, sometimes the backup of pressure will blow off, if you like, or decompress into the right atrium. And so the gradient of the triatriatum or through the left atrium will be underestimated. So we need to just pay particular attention, like in all things with congenital heart disease, to the coexisting lesions because they do impact on our assessment. This triatriatum can also appear on the right atrium, and in this situation it's referred to as triatriatum dexter. Surgical intervention is really the only way to overcome this. It doesn't tend to regrow this membrane, so once it's repaired, this condition is considered to be repaired. Moving on to the supramitral ring. So this is very similar to the triatriatum, but the supramitral ring is always inferior or lower than the left atrial appendage, and that's how we differentiate between triatriatum and a supramitral ring or membrane. The terms are sort of interchangeable. So similar sequelae, we get that pulmonary venous congestion, backup of pressure into the lungs. The membrane can adhere to the mitral leaflets, and so that can cause further valvular damage. Here's an example in a parasternal long axis view. You see the membrane there nicely, and this one has a mean gradient of 4 millimeters of mercury. So both these conditions with these anomalous membranes do cause obstruction. They're considered to be obstructive lesions. Here we see the four-chamber view, and we can see the shelf. It's very, very close to the mitral valve on the left, and then on the picture on the right, we can see that there is actually a PFO here, and this is decompressing. So you can see there is continuous flow across that PFO in both systole and diastole. So it would be easy to underestimate the forward flow gradient through the membrane and through the mitral valve. Moving now to the double orifice mitral valve, this can be seen in isolation. We see It's best seen in the short axis view where we have these asymmetric orifices. You can see two orifices opening nicely there in the short axis view, and no real consequence in the flow there with the colour. They often are asymmetric, and there's a little bit of a clue sometimes in the parasternal long axis view. So, for example, in the image on the left, you can see that there's quite a reasonable valve opening. The leaflets look a little restricted, but they look okay. But with some slight angulation more sort of anteriorly, we see that the valve orifice looks quite different. When you're panning through the valves and you notice these different orifices, that's sort of the clue to be confirmed in the short axis view. Another clue here we see in the four-chamber on the left, we see that there's a significant MR jet that doesn't seem to be associated with an orifice, and that's just because that orifice is out of plane. So we're seeing the more lateral of the orifices with the inflow, but the MR seems to be arising from the more medial orifice. And then in the two-chamber, or the long axis view that we have on the right there, you can very nicely see there are two inflow jets. So in this particular picture, we've captured both inflows simultaneously in the one plane, and that's always a very nice image to capture if you can get it. Now, 3D can really add to this. So this is a case that we did in our lab, and what the 3D revealed was that there was all this abnormal subvalvular apparatus. There was an accessory papillary muscle, and the chordae were really fused. So it wasn't just the valve leaflets themselves that were involved in this condition. There was a little bit more to it, and there was subvalvular involvement. This patient also had a coarctation and a bicuspid aortic valve, and both of those lesions had been corrected. These are commonly associated defects in this patient population. This also can be associated with atrioventricular septal defects, so they do tend to come in clusters. They can occur independently or in isolation as well. Moving now to the subvalvular apparatus with the parachute mitral valve. When there's a true parachute mitral valve, there is genuinely one single papillary muscle, and that's the definition of a parachute mitral valve. Because we have this single attachment point for the chordae, that restricts its opening. So it's like the valve is tented, if you like. That results in mitral stenosis. There is another condition called the parachute-like valve, and that's when there is these two papillary muscles that were really abnormally close to each other, and that's more commonly what we would see in the adult population. Usually with a single papillary muscle, a true parachute mitral valve, we tend to see those, they tend to present earlier in life in childhood. So for LV inflow assessment, these lesions all give similar symptoms to mitral stenosis, so pulmonary venous congestion, backup of fluid or pressure in the lungs. They're commonly associated with LV outflow lesions. Shown complex is one of the conditions we need to be aware of, and that will present with LV inflow and outflow obstruction. So we're getting obstruction at multiple levels, and that results in these sort of heart failure-like symptoms. So let's get on and talk about LV outflow lesions. We're very familiar with this within our adult cardiology. We see aortic stenosis all the time. So let's talk about some really back to basic concepts in echo and physiology and how we need to apply them when we are considering LV outflow lesions. So the assessment of LV outflow is really primarily assessed through the use of our Doppler gradients. And so we need to apply some really fundamental concepts of both physiology and the technical aspects of echocardiography. Talking about physiological principles, so we know that the stroke volume is really this complex interplay between the preload, the afterload, and contractility. So let's just step back for a second and consider what preload and afterload really are. So preload is kind of a diastolic concept, isn't it? It relates to wall stress. It's a relationship of filling pressures, the end diastolic volume, and the LV wall thickness. So all these mitral inflow lesions, they affect our preload. And then afterload is a little bit more about what happens in systole. It's defined as pressure in the LV wall during ejection, but it's affected by blood pressure or outflow obstruction. So these are the things that elevate the LV afterload. Changing topic a little bit here. Now we go back to the basics of echo. So the fundamentals of Doppler. This is Johann Christian Doppler, who was an astronomist and also a mathematician, and he really wrote this equation called the Doppler Shift, which we use in every patient that we scan every time we turn on either the colour Doppler, the pulse wave Doppler, or the continuous wave Doppler. So you really come back to the mathematics involved in echocardiography. And the key part of the equation here is cos theta. So cos theta needs to be as close to 0 as we can make it. Our clinical application of this is that the angle of incidence is everything in echo. When we are assessing the aortic valve, which is highlighted in yellow in this image, we need to use multiple imaging windows around the chest to make sure we can get that angle of alignment between the ultrasound beam and the actual flow, which we can't see, as close to 0 as possible. So we traditionally take our gradients from the apical views, but we should also take them from suprasternal and from the right parasternal, the right sternal edge views. Sometimes we don't feel confident that we've got the right gradient, and so we can try more off-axis imaging. We can use the right clavicular notch, the left clavicular notch, and sometimes even we need to resort to using subcostal. So we do all of this to ensure that the angle is minimized. Every international guideline talks about use of the non-imaging probe. So you may be familiar with this movie Karate Kid. This is Mr. Miyagi, and Mr. Miyagi teaches Daniel-san that men who catch fly with chopsticks can accomplish anything. And this is really about practice. It's about practice and repetition, and every sonographer or everyone who picks up an echo probe should be able to use the PEDOF probe. So I say sonographer who catch gradient with PEDOF probe can accomplish anything. This is another guy who's really influential in the echo world, and this is Daniel Bernoulli. So what he did was he set the relationship between increasing velocities and pressures falling. So as there is an increased pressure differential across two chambers, there's a very high velocity between them. We apply this all the time in our aortic stenosis patients. The Bernoulli equation is actually quite complex, and in most parts of cardiology, we can ignore lots of these different elements. Convective acceleration, though, is actually really important. And when we're assessing valvular lesions, we are measuring essentially the convective acceleration. So this occurs whenever there is a change in the cross-sectional area of flow. Flow acceleration generally in echo we tend to ignore, and viscous friction only becomes relevant, not so much intracardiac, but if we're talking about things that we see in congenital imaging, like BT shunts or long tubular narrowings, even coarctation, this can come into play. So in general cardiology, we simplify this formula, and whenever that V velocity, that V1 velocity is greater than 1.5, we need to correct our Doppler gradients. Most of the time, though, we can just use this very simple formula of 4V squared on the velocity equals our pressure gradient. But sometimes we do need to step back to this modified Bernoulli equation and account for those elevated pre-stenotic velocities. So LV outflow lesions are way more than just LVOT obstruction. So we can see that, like in the left ventricular inflow, obstruction can occur at any level through the LV outflow, including up into the aorta and around the bend to coarctation. So let's start at the beginning. We'll talk about subvalvular obstruction. And subvalvular obstruction or obstruction in the LVOT can be dynamic, like we see it in HOCM, or it can be fixed with either a ridge or a membrane. And look at the difference in the Doppler shape, in the Doppler signal. This gives you an indication of the anatomy behind the obstruction. So we'll just talk about hypertrophic cardiomyopathy just very, very briefly. This is a patient who we saw who, during the regular echo, had a peak gradient through the outflow tract here of 2 meters per second. We asked the lady to Valsalva, and we were able to get a velocity of 3 and a peak gradient of 38. And then we got the patient to sit up, and we were able to further exacerbate that gradient by getting the patient to sit upright. So what's happening here? Remember that HOCM is a really dynamic lesion, so it's very sensitive to changes in preload. And when the patient is lying on the examination couch in the echo room, the forces of gravity are really evenly distributed throughout the patient because the patient is lying horizontal. But as we get the patient to sit or even to stand, those forces of gravity change, and we get venous pooling, and there's more blood in the feet than there is in the upper part of the body. And so it's always wise to capture that gradient not just at rest, but also with Valsalva and with changing the patient positioning. If you can get your patient to stand, that's even better, but not all patients can manage that. So that's how most of our patients experience their symptoms. They spend most of their days upright, and so it makes sense to do that as they make that change in position. Now, moving on to fixed LVOT obstructions, this can either be a membrane or a ridge, which are really the same kind of thing, or a lung tubular tunnel kind of obstruction. These are a very nice case, so we can see the little nubbin on the septum there, but this is more real life, and sometimes this is all you get. So it just pays to really zoom in on these views. Particularly what happens here is the aortic valve leaflets are opening well. They look thin and mobile, but we get a gradient across the outflow tract. But this parasternal view can be really deceiving. So what we see just as this very little membrane or little outreach in the parasternal long axis view, we don't really know the effect of that until we turn to the short axis view. So you see, if we draw a line, we don't really know if we're going to get the top option or the bottom option here. We cannot tell the severity of stenosis just by looking at the parasternal long axis view, which is where we tend to detect it. So this is the same patient that I showed you with the difficult images, and we can see there's quite a significant subaortic membrane in this patient. I'll show you now some apical 5-chamber views. You see the membrane on the 2D imaging. You see the turbulence arising in the LV outflow tract. And we also see that there's aortic regurgitation. And that's really common. And it's common because we now have turbulent flow forcing the valve to open. And so there's sort of repetitive injury or collision, if you like, or those blood cells are really accelerating towards the aortic valve, and that causes fibrosis and scarring, and the valve does tend to leak. In this particular case, we got a peak gradient of 43 with a mean gradient of 27, and you can see that the signal looks exactly the same as an aortic stenosis signal. It doesn't look like a HOCM. It's not late peaking. It's early peaking, and we have a valve. The 2D appearance of the valve doesn't correlate with the gradient. So we need to look really closely at the origin of the turbulence on the colour flow imaging. Congenital aortic valve disease, you'll be really familiar with bicuspid aortic valves, but this slide is just to show you that you need to assess the aortic number of leaflets in the aortic valve when the valve is open. So the top line here is diastole when the valve is closed, and the bottom row of images here is in systole. And you can see that there's not that much difference in the appearance between the unicuspid valve on the left and the normal trileaflet valve second from the right. They don't look very different in diastole, so it's really important to assess the number of leaflets when the valve is open in systole. You can see there's a very nice quadricuspid valve in there as well. Now, the natural history of bicuspid aortic valves, I'm sure you're all very well aware of this. We know that these valves do tend to become dysfunctional, either with stenosis or regurgitation. We know that they are subject to infection. We know that they are associated with aortopathies, and we know they can also be associated with syndromes like Turner syndrome or Marfan syndrome, and we do see these in our adult congenital clinics. But it isn't such a thing as a simple bicuspid aortic valve. So on the left, we have what we call true bicuspid valves. There is only 2 sinuses and 2 clearly defined leaflets with no raphe. And then we have the functional bicuspid aortic valves on the right, where there's various combinations of fusion of 2 of the leaflets. There's been a lot of work that's gone into this, seeing if we can predict what kind of dysfunction, whether stenosis or regurgitation, based on the anatomy. Quadricuspid aortic valves are quite rare, actually, but we see them all over Twitter if you're a Twitter fan. So we think they're much more prevalent than they really are. You can't take what you know about bicuspid valves and apply it to quadricuspid valves. They are quite different entities. So aortic stenosis is quite uncommon in a quadricuspid aortic valve. More commonly, you will see regurgitation. They are associated with coronary artery anomalies, and the root of dilatation, it's rare, but it is reported. But coarctation is very rare. So the morphology and the pathology that we normally see behind quadricuspid aortic valves is quite different to what we would normally see with our bicuspid aortic valves. So moving on to supravalvular aortic stenosis now, this is an autosomal dominant condition. We usually see it with Williams syndrome, and we see a really nice angiogram here where the supravalvular aortic stenosis is quite striking. Unfortunately, on echo, it doesn't always appear so striking, and it can be really easy to miss. So this patient has supravalvular aortic stenosis, and you might just notice that at the level of the sinotubular junction, it just narrows down a little bit, and sometimes on the 2D findings, it can be very, very subtle. So here's a zoomed in view. Again, even the measurement isn't particularly unusual of 2.3, but I will go ahead and I'll show you the Doppler. So on the apical 4-chamber view, just doing a routine scan, peak gradient of 16, again, very easy to miss, but you need to also employ your clinical suspicions. You know, if there is a murmur, go looking for something, particularly in a patient who has Williams syndrome, and by using the non-imaging probe from the suprasternal notch, so up here in the arch views, we were able to get a peak gradient of 47 and a mean gradient of 21. So, you know, in the realms of moderate aortic stenosis, which could have been actually very easily missed. Supravalvular AS is generally repaired by this aortoplasty. They kind of resect the ridge. They can open up the aorta if necessary, and then they re-anastomose those two segments of the ascending aorta together. Okay, so now we'll move on to aortic coarctation, and this is actually one of my favourite lesions, and the way I like to describe this is thinking about the physiology that happens before the lesion and the physiology that happens after the lesion. So if we consider what happens before the lesion, we have this very tight narrowing and we have a backup of pressure. Now that pressure transpires in multiple ways. So we might notice an elevated blood pressure, we have increased afterload on the heart, and so we might see signs of left ventricular hypertrophy, and we have a buildup of pressure also in the brain, which can predispose patients to cerebral aneurysms. Downstream of the lesion, we have reduced flow, and this is what can cause this particular condition to be really life-threatening. So we could have ischemia to the gut and to the viscera, so multi-organ failure, multi-organ ischemia, which is a life-threatening emergency. We can have claudication, the classic clinical sign, reduced femoral pulses, and we can also have some degree of cyanosis. So coarctation of the aorta can happen in multiple locations up there in the aortic arch, and we usually describe it in children at least in a position relative to the ductus arteriosus. So a pre-ductal coarctation will actually increase the cyanosis because there will be flow from the duct mixing with the blood, so that deoxygenated blood that's coming from the pulmonary artery through the duct into the descending aorta. So you might have a differential cyanosis where the feet are blue. Now, on a preoperative echo, we need to correct those gradients for proximal flow, especially when there is coexisting or concomitant aortic stenosis. So this is when we need to apply that information from the Bernoulli equation, and we might need to correct our V1 velocity. So take, for example, the situation where you've got a patient who has a bicuspid aortic valve with severe stenosis and a coarctation. If there is a velocity of 4 or 5 meters coming up the ascending aorta, it's quite reasonable to expect that there will still be high velocities before the coarctation, so as that flow goes around the bed. So that flow won't normalize just in the proximal descending aorta. So we need to consider that proximal flow prior to the coarctation. We may need to use this modified Bernoulli equation to correct these gradients to ensure that we're not overstating the gradient. This is a classic Doppler signal on what we might see. So if we have a significant stenosis, we see this diastolic flow. So we do see an increase in the velocity, but the key point here is this diastolic continuation of flow. This is classic for coarctation of the aorta. And the reason for this is twofold, I'd say. So one is that there is a continuous diastolic gradient because the narrowing blood, the narrowing of the aorta really stops that blood from clearing or passing through the descending aorta. And what that does is it backs up the pressure and backs up the blood flow. And what that does is it extends all these vessels. So all of these normal little intercostal arteries, which carry really minimum volume of blood, start to become a major player and carry a significant amount of volume to get the blood lower down into the descending aorta so that it can feed the organs, the gut. So that's why we get this diastolic flowing of blood. We get all these collateral vessels forming. And here's a really nice example of why it's the diastolic flow that's important and not the aortic, not the peak velocity. So this is a 26-year-old male who presented to accident and emergency with acute onset chest pain a few years ago. He was a medical student, so he insisted on having a CT scan because he had had chest pain. He felt that he had had a pulmonary embolus. It turned out that actually on the CT, it demonstrated an acute aortic dissection. So he was referred to a tertiary centre and he had urgent surgery. This is his intraoperative TOE, so we can see the patient has a bicuspid aortic valve, hugely dilated ascending aorta of 7 centimetres, and he had a type A dissection as well. That was repaired. He had a mechanical aortic valve replacement and a root replacement, and then he had a follow-up MRI scan, which raised the question of coarctation, and so he was sent to our hospital for follow-up. And generally speaking, the valve works well. The intracardiac anatomy here is pretty unremarkable. But then we get to the arch views and we see this arch reasonably unremarkable, but the colour flow looks a little bit unusual. We're not seeing turbulence. We're not seeing very much at all. And we have this velocity here, so 1.2, totally normal velocity. So that certainly doesn't really fit with the picture of coarctation. When we did the abdominal aorta, though, this is from the subcostal view, what we do see here on both the colour flow imaging and the Doppler spectrum is this diastolic continuation of flow. So it is this flow here that tells the story in this patient. So this suggests there is a collateral circulation. So we need to ask, why is there a collateral circulation in this patient if we don't have any evidence of a coarctation? So this is the patient's CT. We can see there is a very, very tight coarctation here and multiple collaterals. There's the narrowing. So you can see that it is incredibly tight, and you can see all of these collateral vessels which have formed, all these intercostal arteries which are really just kind of ballooning out, so to speak, now that they're carrying so much blood flow. The patient went to the cath for consideration of stenting, but they couldn't pass the wire retrograde up the descending aorta. So we see the vessels coming into the descending aorta there. They used a coronary wire to open this tiny, tiny narrowing. You can see how severe this coarctation is. They had to come in from the radial approach to get that catheter into the upper part of the descending aorta. And so a stent was put in there, and we had a really nice result from the angio that blew up that narrowing. There's a nice big stent in there now, and so normal flow is restored. Now, this is the pre and the post image. So they're really very impressive, really nice work from our percutaneous, from our interventional team. And here is the CT, both pre and post. And now let's look at the echo, pre and post. So images on the left are the preoperative scan, and post-op you can see the stent here. You can see the stent just protruding into that area in the arch view there. So when we look at the colour on the image on the right actually looks more turbulent than the image on the left. And so that's a bit of an unusual finding, and we would not expect that now that that vessel is really opened up. Here are the velocities through that area. So preoperatively, the velocity was there at 1.2 meters per second, and post-op, it's around 2. So we're getting more flow through this area now, but the gradients have gone up. And here is the abdominal aorta, really diastolic continuation of flow with very low velocities in the pre-stent images, and in the post-stent images, we're seeing much higher flow in systole and significantly less flow in diastole. So what's really going on here? Let's go back and look at this preoperative image. Now you've seen the collocation. You know how tight this descending aorta was. You know how tight this lesion was. So what we really see here is the blue flow is blood coming around the arch, and you see this red flow here. This flow is essentially swirling. It is not passing through the descending aorta. It is coming and swirling and then going up the collaterals and coming down. So the majority of the blood flow is via the collaterals. Let's go back and look at the trace, the Doppler trace from this arch view. The velocity is really not very high at all. That was not the key indicator here. This is a very extreme case, remember. But look at the diastolic continuation of flow. It is there. And so it's these very subtle signs, these nuances of looking at the Doppler. The abdominal aorta was the clear giveaway with very strong evidence of diastolic flow continuation. So how to repair this lesion? This particular patient was stented, but there are actually a whole lot of surgical options. It's important to be familiar with what they all are, particularly this last one here where there's an ascending to descending bypass. So we may or may not see that on an echo, but the important thing in this particular patient is the coarctation will still be there, but because there is no backup of pressure, the flow is all going down through here, so there won't be a gradient. But the native coarctation, the narrowing will be there. It's just that the pressure has been relieved through this extra graft. Here's another example from our lab. This is a 45-year-old male who has had a coarctation repaired many years ago, and he had ongoing hypertension. So we did the echo. This is his, again, the intracardiac anatomy is fairly normal, fairly unremarkable. This is his suprasternal view. And again, we see this diastolic continuation of flow. See that blue flow, it just lingers around, doesn't it? And we also see that on the spectral Doppler. But there's really good flow going through here. So we're not suspicious of a narrowing, but what else could there be? We don't see the same degree of diastolic flow in the abdominal aorta. So this actually is a different situation. We gave this patient contrast, and what it shows, so this is the aortic arch view with contrast, and we see this very big area of contrast here. This is very nicely shown on the CMR. So what we have here is a very large aneurysm at the site of the coarctation repair. And it's just really important to remember this is a common complication post-coarctation repair. We always think about re-narrowing. We know that that can happen, but also remember that the opposite might be true as well. And we can actually get these quite significant aneurysms which need to be addressed. So we need to be careful when assessing LV outflow, particularly when we have serial stenosis. So in the example of a bicuspid aortic valve and a coarctation, remember these modified Bernoulli equations. The issue here is that we can very easily detect the difference between V1 velocity and V2. So we can correct for this situation, but if we add another stenosis in here, we really need to do a V3 minus V2, but we never really know what V2 is. And so when we have serial stenosis, we do tend to overestimate these gradients, and that's really important to keep in mind that the echo data, if the echo data isn't matching up with your clinical intuition, then there could be an error in the gradients. This is irrespective of angle or any of those other things. So it is possible for echo to overestimate the gradients in the case of serial stenosis. And that comes up a lot when we start going back. Remember I mentioned before Schoen complex. So shown complexes when we have the inflow lesions, parachute mitral valve, supramitral ring, with outflow lesions of the subaortic membrane and collocation. So we've got multiple levels of obstruction here, lots of factors affecting the stroke volume and the cardiac output. This is commonly associated with the underdevelopment of the left ventricle and the aorta. It presents with heart failure type symptoms and generally requires intervention of maybe one, maybe more of the lesion. So we need to really try and tease out which is the culprit lesion here. So we need to take care when assessing LV outflow. There are lots of concepts that I have not covered in this presentation. So things like low flow, low gradient, and the role of dobutamine stress echo. I haven't talked at all about flow rate. I haven't talked about pressure recovery. And this is important when the ascending aorta is hyperplastic or less than 30 millimeters, any kind of long tubular obstruction. I haven't talked about energy loss, stroke work loss, impedance, or any of these kind of more advanced aortic stenosis type of concepts. They're really nicely outlined in the European guidelines though. Overall, when we look at LV outflow lesions, our echo assessment requires a really excellent understanding of both the physiological conditions, subjects of preload, afterload, contractility, how are they affecting the measurements that we're getting on echo, and then also the assumptions used in echo physics and maths. Remember, we have to study these concepts when we sit our accreditation exams, but we need to know when to apply them into our clinical practice. So be aware of the shortcomings of the Bernoulli Equation, of the Doppler Equation. Remember, angle is really important. Remember, we can get into trouble in echo when we have serial stenoses. Each level of obstruction for both inflow and outflow lesions has its own sequelae, so we need to be understanding of what that is. And the echo obviously provides really important information for both patient management and consideration of intervention. Remember, if you're getting gradients and the aortic valve has thin and mobile leaflets, think about those subaortic and supraaortic conditions, which can be really easy to miss. Thanks very much for sticking with me throughout this session. I hope you've learned a trick or two, and that's it for my presentation. Thank you.
Thank you, Ms. West, for very comprehensive and very interesting presentation. I think we could start for a couple of minutes discussion with Professor Ho. Here is also a couple of questions, Professor Ho. I will starting with this, which is more morphological. How do you think it's possible the mitral cord attached to the outflow tract will be thus accessory, which can be removed during the cardiac surgery on those of guide patients with congenital heart disease?
Generally, the ones I've seen are accessory, but I would advise look carefully on a case-by-case basis.
Yeah, this is the most important. There is another one question, I think is from one of our audience from Malaysia, who is very active. How do we differentiate the echo through mitral stenosis from increased flow? I think the main recommendation that for echocardiography, it's very well established for the patient with the mitral stenosis. The typical changes from the echo of the mitral leaflets, it's very important to look at about, but increased flow, it's could be mentioned from the different type of gradient of the late atrium, and we could differentiate also when we look at of the mean gradient. The mean gradient is most important for the differentiates from the increased flow on the mitral stenosis flow, which is dependent from the area of the mitral valve. But I think there is something very interesting that we could also discuss with Professor Ho regarding the adult with postoperative changes in aortic rotation. The aneurysm that we could find is very often, and how we could manage these patients to go mainly for the cardiac surgery is not preferred for the adult with the aortic rotation. The stenting is most uh, initiative that it's preferred from this kind of population regarding the differences of the neurological condition there, and we could send anyway from the in the cath lab this kind of population. Did you hear me? Oh,
Well, I'm not really in a position to answer that sort of question, but increasingly the trend is, of course, through transcatheter management of these lesions. It takes really expert hands to do that.
yes. The transcatheter is this, and then maybe with the follow-up of this kind of patient with the MRI and cardiac MRI is most important to see how it's going for the post-procedural lesion of after the cath lab in the near ages. So I think there is no other questions.